Okay. All right. So yes. All right. Well, we're just going to get into it. Next slide, please. All right. So today, what I'm going to be talking about is something that I'm really excited about. And I hope that I'm going to convince you of some interesting things that are coming up in the world of SGLT2 inhibition. I'm going to very briefly cover the history of why SGLT2 inhibitors matter. But my main focus is going to be on the mechanisms behind the mortality benefits seen in SGLT2 inhibitors. Like we know why they're great. Well, we know they're great, but we don't know why. And that's going to lead me into this introduction of a concept called estivation, which we'll talk about. And ultimately, I think my main focus is going to be the metabolic changes that happen with SGLT2 inhibitors. And so I'm hopeful that it'll kind of spur some interesting thought, discussion, and that it'll be interesting for researchers and clinicians alike. Next slide. So very briefly, there's a lot going on in the slide, but SGLT2 inhibitors have only been around for maybe the last like 10 years or so. I think the first major trial that came out was EMPA-REG, which basically showed that empagliflozin lowered the risk of cardiovascular events and decreased the rate of CKD progression in diabetic patients. And from there, we had a lot more studies come out showing that, that you also decrease heart failure hospitalizations, decrease risk of death, and eventually with, the DAPA heart failure and DAPA CKD trials, they eventually show that it doesn't actually matter if you have diabetes or not. You're still going to see this mortality benefit. You're still going to see this decreased CKD progression and decreased renal and cardiovascular mortality. So, and then emperor reduced and emperor preserved are basically just, proving a point that you can have reduced ejection fraction or preserved ejection fraction with or without diabetes, and you also still see the same cardiovascular benefit. So, I mean, this kind of leads to the next slide / next question of why do we see this incredible mortality benefit? With or without the diabetes, you still improve morbidity and mortality. So the thought is the mechanisms must be beyond just diabetic control and sugar control, essentially. Next slide. So it kind of enters like the first couple of theories as why this was happening. And I think a lot of the nephrologists early on will say that I think the most popular theory was this tubular glomerular feedback. And that was that the SGLT2 inhibitor would help to deliver sodium to the thick ascending loop and the macula densa. And there would be this paracrine adenosine signaling that causes afferent arteriolar vasoconstriction, and that you have decreased glomerular blood flow. It's essentially decreasing intraglomerular pressures and kind of helps reduce that hyperfiltrative state. There's been some other theories like direct protection against podocyte remodeling, even in the absence of diabetes, because SGLT2 is expressed on podocytes and upregulated in proteinuria. And then, of course, a lot of people also were thinking this is all hemodynamic. You have natriuresis and diuresis, so you have improved preload and afterload reduction. But I think there was criticism that, this doesn't fully explain why there's cardiovascular benefit, why there's this like kind of like full body multi-organ protection, which leads to additional theories on the next slide. So there's like a lot of research that came out and a lot of theories that came out. These are just some of the popular ones. It's been shown to be anti-inflammatory, anti-fibrotic, kind of inhibiting aberrant hypoxic or hypoxia-inducible factor 1A. And it decreases collagen synthesis and decreases differentiation into myofibroblasts, et cetera, et cetera. There was evidence that showed there's decreased oxygen consumption in the early proximal convoluted tubule, which was kind of interesting. That's also still very like in the air, and there's a lot of developing data on that. There was endocrinologist who proposed this idea of the thrifty substrate hypothesis. Basically, he was saying there must be some metabolic thing, i.e. ketones, I think was the most popular one at the time when he first kind of brought it up, that is much more oxygen efficient and can produce ATP in a very, very efficient way. And that was how the SGLT2 inhibitor worked. And there's also data showing that there's improved autophagy and lysosomal degradation, especially in the heart. And that there's decreased uric acid and fructose metabolism, and it helps to modulate the Warburg effect. And the latter one actually came from one of our own, Dr. Johnson, who recently published this idea in mid-2021. All right, next slide. So this is just kind of like I found this really nice kind of diagram that kind of shows all the theories that have been kind of proposed to date. I'm not going to go into it too much, but I thought an interesting theory came about on the next slide. It came through. This was this it's something that is seen in creatures who live in high salinity environments, arid conditions, and they're really good at conserving water. And there's a lot of crosstalk between all these metabolic pathways that they thought was really interesting. And in this review, I thought it was very thought-provoking. And they they proposed that perhaps this concept of estivation is really where the organ protection by SGLT2 inhibitors come from. Next slide. Estivation is, the best way I can put it is it's kind of like hibernation, where, it's very cold, not really great living conditions. You sleep for like several months. You come out on the other side, having lost a ton of weight. You've been through this hypometabolic state. So estivation is the same concept, but hot or dry. And the main thing that is seen is just water conservation. So this is often seen in amphibians, animals that live in high salt environments, like brackish water. Amphibians are also moving from dry land to water. It's also seen in desert animals. So it's this conserved motif through evolution that some researchers have seen in other animals. It's ultimately a really great survival strategy that can suppress the metabolic demand up to 20 to 30%. And the thought is that the depression of the metabolic state reduces turnover of macromolecules that ultimately extend the functional lifespan and promotes antioxidant defenses. But the bottom line is that estivators, so animals that can do estivation, conserve water through osmolyte production. We're going to talk about how that happens. Next slide. Thank you, Ruth. So this table is kind of a lot, but I'm going to try to break it down the best I can. So on the left column, we kind of have like baseline, unlimited fuel, unlimited water, there's no stress. That gray thing is a lungfish. There's a frog there, mice are happy. So this table is essentially kind of comparing what non-mammals and mammals would do in kind of a high stress environment that would theoretically induce estivation. For mammals, eating a high salt diet can essentially induce an estivation-like state. So going on to the second column, we have unlimited fuels, but we're starting to get into dehydration stress. The amphibians and such, they're still okay. The mammals are, this can be induced by a high salt intake, like I mentioned. But the thing with estivation is that it's a very demanding process. It requires a lot of energy. And so when fuels are unlimited, animals will eat whatever they can get their hands on. Some and animals use as fuel. Moving over into the third, really start to see estivation kind of do its thing. You have more limited access to food. You have still limited access to water. And because of that limitation to access to fuels, your energy intake is essentially forced to what it probably normally is, to normalize the caloric intake. You still have, a thirst drive. And this is where the fuel switches really start to kick in. And you see a lot more metabolism, and talk a little bit more as to what kinds of stuff we see. And then this is, I think, that kind of Goldilocks region where we see kind of benefits with SGLT2 inhibitors, which I'll go into. The far right column is where we see like true blue estivation, where some of these animals, these amphibians and non-mammals, when they absolutely have no access to fuel or water and they're severely dehydrated, they almost essentially go into this hibernating kind of lost a lot of it. I'll talk about this a bit more, but I think people on SGLT2 surgeries and PO at midnight, that is where we see a lot of like problems. I think we'll see subsequently. So sorry. Okay. Next slide. I don't know where I last ended, but if it's easier to look to digest that table in words, this is the slide that does it. Basically, non-mammals are better at estivating than mammals for reasons that are unknown. But we'll see on the next slide, the way that estivation happens is that you have more production of urea that basically helps to produce this kind of like osmotic gradient, particularly in the medulla, to help resorb as much water as possible while still excreting extraneous salt. And the slide is crazy. I'm gonna try to break it down. So at the top, we have something called the Cahill Cycle. It's a metabolic pathway that essentially connects skeletal muscle with liver. And so we'll take the mammal, for example, so the mouse. So on a high salt diet, the liver will start to produce more urea and kind of begin this estivation process, which is a very, very high energy consumptive process. And so when food resources are high, we eat the calories we need, we eat the protein we need, and that helps to make the urea, which is ultimately resorbed into the medulla, to ensure that there's a strong concentration gradient that helps to resorb all that water and prevent kind of like an osmotic diuresis from whatever salt load that we have. When food sources become low, that is where we start to tap into our endogenous fuel storage, for example, in the muscle. So our muscle is a really great storage for nitrogen sources. And so the muscle is able to kind of essentially make a deal with the liver in this Cahill cycle, saying, we're starving, we gotta do what we have to do for the rest of the body. So the muscle, will produce amino acids for you. If you can make it, for you, the liver, if you, liver, can make the amino acids into glucose, so the rest of the body can benefit from a little bit more glucose. The kidney also looks to the liver for a similar deal, saying, hey, I'm really dehydrated. If you continue to make more urea for me using these amino acids that muscle is making, like from alanine, I will make sure we stay hydrated to the best of our ability. And so that's kind of how these three systems kind of talk to each other in estivation. Hopefully that made some sense. So we're going to move on to the next slide. So the ultimate goal is the urea production. I think that's a really, really key thing to help conserve water and decrease urinary levels of free water. This slide is just to kind of summarize what I talked about, and that for mammals, a high salt diet kind of induces all of this. And when the food sources are limited, we start to tap into our amino acids, ketogenesis starts to kick in, and we're less reliant on glycolysis, because glycolysis is actually not, and it's fine, but it's not nearly as efficient when you look at hard numbers of like ATP produced per pyruvate, acetyl-CoA, whatever you want to call it. The other interesting thing that I hadn't mentioned, but that was in the previous slide, was that when the urea is resorbed into the medulla via the urea transporter, the other thing that has been noted is that there's evidence that SGLT2 inhibitors also induces antidiuretic hormone, ADH, which is interesting because it further facilitates this urea transport to kind of help with this estivation process. And so y'all are probably like, okay, that's all fine and great, but what is this actually applicable to humans? And the argument is yes on the next slide. So there was actually this really cool study that looked at humans on a high salt diet. They weren't on any sort of ACE inhibitors or ARBs. They did have hypertension, so they were on some kind of calcium channel blocker. They, for the most part, had essentially normal kidney function. They looked at folks who had a low sodium diet, which is less than about 2 grams a day, medium sodium diet up to 5 grams a day, and a high sodium diet greater than 5 grams a day. And what they showed on the leftmost graph here is that the higher the salt load, the more sodium excretion by the FeNA. But then those high salt diet folks will also excrete less water, while the potassium, which I'm kind of interpreting as a control, the potassium excretion is the same. Looking at the middle graph, the red dots are basically, this is a volcano plot showing kind of a lot of the metabolomics, and the red dots are showing that intermediate and end products of the urea cycle or protein catabolism are very much highly upregulated. And they kind of prove that point further on the most right-hand kind of table. basically breaking down what amino acids they're seeing that are upregulated or not. I think the ones to highlight are leucine, and valine. Those, it's kind of the striped ones. Those are branched chain amino acids that can be utilized in ureagenesis and also for energy and ATP production. So those were the ones that are really critical in this whole estivation process, and they've showed that those are also increased in this process. Okay. So now I think the question is like, okay, this is all fine and dandy, but how does this apply to SGLT2 inhibitors? We can go on to the next slide. The way that this happens is that the SGLT2 inhibitor not only is dehydrating through natriuresis, but it also limits how much glucose you have available in your bloodstream because you're peeing out the extra sugars. There's a lot of studies that kind of hint with this estivation process and whatever, but the bottom line is that there is really compelling evidence that there's like very, very interesting metabolic changes that happen with SGLT2 inhibition and very profound fuel switches, which we'll talk about in the next slide. So there has been various studies here and there that show that there is some loss in lean muscle mass due to this altered metabolism, probably from tapping into all those fuel storage in the muscle. And the question was, okay, well, if someone's on an SGLT2 inhibitor for a long, long time, are we going to continue to lose lean muscle mass? And the answer is no. And the reason why that happens is because that ketogenesis and the fatty acid beta oxidation ultimately helps to conserve a lot of that muscle mass, so that protein catabolism isn't the sole source of glucose and energy. The ketogenesis and the fatty acid oxidation is really interesting to think about because physiologically, the heart predominantly relies on fatty acid oxidation to produce ATP, but it's also really good at using ketones. So I think this fuel switch and this kind of hypometabolic state might actually be what drives this reduced sympathetic drive, reduced heart rate and afterload reduction that has also been seen in various studies. Talking about fuel switches in the kidney, it's a little bit more complex. We're going to talk about it in greater detail, but it's very complex when diabetes is present. But it's felt to be somewhat like cardiac metabolism, where the kidney will start to use more ketones and fatty acids. And we'll also talk about a study that showed that there's aberrant glycolysis that's happening in the kidney in diabetes, and that SGLT2 inhibition also kind of helps to modulate which metabolic pathways we're using for fuel and for ATP production. All right, next slide. And so the first thing I'm going to touch on is solely on the heart. This is SGLT2 inhibition in non-diabetic pigs that have had an MI induced, and they subsequently developed heart failure with reduced ejection fraction. And so basically what's being shown here is that you have the red, which is the control pigs. They haven't had an MI, or sorry, they've had the MI, but they're treated with placebo. The gray is the non-MI, so this is the control, healthy pigs with normal hearts. And then the blue is these post-MI pigs that have been treated with empagliflozin. And so I think the interesting thing is kind of working our way down is that empagliflozin will being uptaken by the heart compared to the post-MI pig that is just treated with placebo. So it helps to kind of normalize the amount of fatty acid. There is reduced lactate production as in, you know, there's these pigs are not using lactate as much, and so there's like less lactate fermentation. There's less glucose available, so indirectly you're kind of thinking, okay, maybe there's less glycolysis. The BCAA, those are branched chain amino acids, so that's the isoleucine, leucine, and valine that I was talking about. So those levels those are being more uptaken in empagliflozin treated pigs. And there's also a heck of a lot more ketone bodies as well, which is seen in E. And as a result, you see the myocardial efficiency kind of goes back up to normal. And they kind of correlated this with enzymatic activity as well. So there's increased like enzymes and ketone body metabolism and branched chain amino acid metabolism as well, which I'm not necessarily going to show the graphs of those. Next slide. And ultimately, what they did show is that when you treat these MI pigs with empagliflozin, the heart actually does have more ATP. And so this is consistent with the notion that the utilization of ketones and these branched chain amino acids and, or fatty acid beta oxidation is far more efficient at utilization of those macromolecules to produce ATP. So the only caveat is that they didn't actually study urea cycle metabolism, which brings me to the next study that I'm going to talk about. And so this is so many overwhelming graphs here, but this one is specifically done actually in humans. This is SGLT2 inhibitors in patients with diabetes and heart disease. And the big takeaway that I want you to kind of gather from this madness is that the red, believe it or not, is increased activity. So you have increased ketone body metabolism and ketogenesis. Glucose is down, so theoretically maybe glycolysis is downregulated. That the ketone body feeds into the citric acid cycle, which ultimately produces a lot of ATP through cellular respiration. And that the urea cycle is heavily upregulated in when someone's treated with an SGLT2 inhibitor. That's the huge takeaway from this graph. And it's very interesting because it was actually demonstrated in humans. So now we're going to look specifically more into the kidney in the next slide. So I'm going to break this down in madness. So this was a very interesting study that was done in diabetic rat kidney. Interestingly enough, they weren't particularly proteinuric, but at any rate, what they showed was, first of all, this ApoE++, this is normal control mice with normal diet. They essentially produced this non-proteinuric diabetic nephropathy model by feeding the ApoE knockout mice with a high-fat diet, and that was able to produce diabetes in this, sorry, I said mice, but these rats. And that was the model they ultimately studied. And what they showed was, I'm looking at the far left, is that there was less ATP available in the diabetic rat. So that's that gray bar. So then they said, okay, what if we just gave them fatty acids or just ketones available for energy production? So that kind of leads to L on that left side. What they showed was that normal kidneys will produce more ATP in the presence of the fatty acid oleate, but the diabetic kidney will produce more ATP in the presence of ketones. So far, no one's been treated with SGLT2 inhibitors. Okay. When you now I'm going to move over to the top kind of K on the right with the colors. So the blue is the control. These are milestones to give a diabetic kind of rat kidney ketones, i.e. that red bar, more ATP will be produced to the point where it's essentially normalized compared to the diabetic kidney that doesn't have ketones. The other interesting thing that they showed was kind of what happens when you knock out HMGS or CS2, which is the first rate limiting enzyme in ketogenesis. So they took these diabetic rats, they knocked out this enzyme. So basically they can't produce ketones. And they showed that renal function remains just as poor in those double knockout rats as the control diabetic kidney, the yellow, suggesting that ketogenesis is really, really important in renal protection. So looking at the bottom two graphs, they further demonstrate that when you treat these rats with empagliflozin, you have improved ATP levels in the diabetic kidney. So that's the red there. And it's improved to the point where it's almost normalized. And then when you look at the same double knockout mice treated with empagliflozin, it produced the ketone being treated with empagliflozin. The absence of being able to produce those ketones, you can't produce as much ATP. And so I think this is a really strong demonstration that ketones and the ability to produce ketones, especially when you're being treated with SGLT2 inhibitors, is really, really important in terms of renal protection. Okay, next slide. Actually, for the sake of time, I'm going to skip this one, but we're going to go to the next slide. So to summarize, because that was a lot of words that I said, in the diabetic kidney, there is reduced ATP production. If you just give the kidney just ketones, even without SGLT2 inhibitors, ATP is produced and all is fine. When you give the diabetic kidney SGLT2 inhibitors, it truly does increase ketogenesis and it improves the amount of ATP available in the diabetic kidney. But then when you abolish that ability to produce ketones, even in the SGLT2 treated diabetic rats, you lose that benefit, you lose that renal protection, despite being on an SGLT2 inhibitor. And so that ketone production is really important. And so that last slide I just skipped was point number 4, was a fun fact. They also looked at mTOR. I'm not going to get into that for the sake of time. Next slide. So now the criticism was like, okay, that was a non-proteinuric diabetic model. I want to see what happens in the proteinuric diabetic kidney. So come this study, this was also recently published. This was a group of folks who induced diabetes in mice with streptozotocin. When they induced the diabetes, they were either treated with nothing, insulin, or empagliflozin. This picture is really pretty because it's very. So on the far left-hand side, this is a normal kidney. The second column shows a diabetic kidney without any treatment in terms of kind of gross, but more, histopathology. The third column shows what happens in the diabetic kidney when you treat it with empagliflozin, and it looks very similar to the control non-diabetic kidney. There's less fibrosis, which is the first and second rows, and in terms of light microscopy, the glomerulus looks pretty close to normal. There's less glomerular damage. And the podocytes that's there on the electron microscopy in the last row also look a heck of a lot happier, which is compared to what happens when you treat these mice with just insulin. And the hemoglobin A1C was the same between the empagliflozin and the insulin group. And yet in the insulin group, you see all these fibrotic changes. You see a very unhappy glomerulus there. Next slide. And so what they found was a couple of things. They identified a gene that was associated with fibrosis and cell differentiation. And this gene, this SGLT2 gene, was also linked with HIF1 expression, as well as something called STAT3. For the sake of time, I'm not going to go into it too much, but in this Western is which are all enzyme glycolysis. Treated with empagliflozin, testing that empagliflozin helps to modulate the amount of glycolysis that is seen in these diabetic kidneys. All right, next slide. This one's a lot prettier. So, we're going to ignore A for a second for the sake of time, because I don't think it's particularly relevant. But what they showed here is that the white is control non-diabetic kidneys. The red is the diabetic kidney that is untreated. Yellow is the diabetic kidney treated with empagliflozin, and green is the diabetic kidney treated with insulin. There is a lot of fructose-6-phosphate and glucose-6-phosphates and phosphofructokinase in the diabetic kidney, and all of those are downregulated once you treat these mice with empagliflozin. And it's downregulated to the point where it's essentially back to normal control levels, which is really fabulous. It's just further demonstration that empagliflozin reduces kind of the amount of aberrant glycolysis, and it reduces glycolytic intermediates as well. Okay, next slide. And so we're coming to the end here. I got a few more slides, but I think in summary, there's a lot of things I think to be really excited about. Number one is, I think SGLT2 inhibitors offer organ protection in a lot of different flavors, including hemodynamics and changes in metabolism. I came across this thing called Hickham's dictum, which is a complete opposite of Occam's razor, where, it doesn't have to be just one pretty thing that kind of helps to, explain everything. But, SGLT2 inhibitors, I think, will do whatever they damn please. And they do a lot. They really do a lot. And I think hopefully I've convinced everyone here that there's really interesting and compelling evidence that SGLT2 inhibitors alters metabolism in a very meaningful way, particularly through ketogenesis, changes in fatty acid oxidation, and glycolysis as well. And hopefully, this concept of estivation in mammals as an adaptive process to conserve water and energy in high stress environments that is ostensibly induced by SGLT2 inhibitors is an interesting idea. I'm not sure if I'm not totally convinced yet that this actually happens in humans. I think there's kind of nice evidence that points in that direction. But I just liked it because I thought it was a very bold attempt at trying to put all of it together and trying to look at SGLT2 inhibitors very holistically. And it was a nice reminder that I think, especially as somebody who's interested in research, to kind of look back and appreciate these motifs that have been conserved through evolution to kind of understand renal physiology. But bottom line is that even though there's all these little mechanisms, all these little things that SGLT2 inhibitors do, there's so many things that have been described. I don't think, this is me just talking, I don't think these mechanisms are mutually exclusive. Like I think at some level, these things are all related. Next slide. Okay, I'm gonna end with how does this all clinically apply? Because we were like, okay, we saw a lot of graphs. They may or may not be meaningful to some, but all this stuff that I've learned about kind of has raised a lot of questions for me. Next slide. And so I kind of briefly kind of talked about the euglycemic DKA, but there was a really interesting case conference with Dr. Charlo and Dr. Dulesky on a cabbage patient who had euglycemic DKA after like 1 or 2 doses of empagliflozin, which was like very profound. But hopefully with kind of what I've shared with you, my thought at least is that, I think this euglycemic DKA is just precipitated by a carbohydrate deficiency and volume depletion when these patients are made nothing by mouth for certain procedures. And the carbohydrate depletion is what really drives a ton of ketones. They have no access to water, so they become very volume depleted, and all of that kind of encourages euglycemic DKA. So that's a little kind of a clinical plug. The next slide shows some other clinical questions that came up for me. The first one being, is a keto diet or intermittent fasting safe in folks who take SGLT2 inhibitors? Or what about people who fast for religious holidays? Question is, probably should be fine. But I think it has to be very individualized decision-making. So my next question was, well, if SGLT2 inhibitors also muck around with ADH, is it safe in people with very advanced heart failure, for example, who have like this non-osmotic drive of ADH and become hyponatremic? The answer is not fully clear, but pointing towards it's probably fine. There's no data to suggest that SGLT2 inhibitors are harmful in acute decompensated heart failure. And there's actually like one really small study that showed that it was maybe even helpful in SAADH, which is kind of interesting. And then of course, I think there's going to be the lifelong question of, do SGLT2s actually cause AKI, or is it like a kind of a transient rise of creatinine that doesn't have a true reflection on the eGFR, kind of like ACE inhibitors? I think it's still a point of controversy. I don't have a great answer there. All right. The next slide kind of ends with several other questions I've had. Like, does SGLT2 inhibitors actually affect the renal angiotensin aldosterone system? Maybe, but not totally convincing data yet, to my knowledge. My theory is that it also probably depends on the disease state that you're studying. And then of course, then the very natural question I had was, whoa, there's this thing I learned called Estivation. Do all diuretics do this? And if not, do diuretics and caloric restriction do the same thing? And there's no data yet. And last but not least, the other clinical question I had was, should we be giving SGLT2 inhibitors in patients with acute MI or AKI? Because my thought was, does the altered metabolism decrease the amount of oxidative stress or whatever, provide different macromolecules for ATP production and maybe help the injury? No real good data yet for MI. Maybe there was like a study of like 100 patients that got SGLT2 inhibitors. Actually, 50 of them got SGLT2 inhibitors post MI. The other half got placebo, and it was looking kind of promising, but it wasn't very convincing. And for AK, there's certainly no data yet. So those are kind of the questions I have. And so I think this is a very exciting field for nephrology. And hopefully we'll develop more answers as we kind of move along here. And with that, I end on my next slide. Questions, comments, feedback, concerns. I apologize for my internet issues today, but I appreciate everyone's patience with me today.
Amy, that was very nice. That was a tour de force. Go ahead, Rick. You look like you
have I was going to make a comment. First off, Amy, that was beautiful overview. Thank you. So what a lot of damaged tissues do is they kind of go into a protective form in which HIF-1 alpha is activated because there's local ischemia. And HIF-1 drives a protective response by stimulating glycolysis, reducing mitochondrial function. So it's initially a beneficial response, but chronic HIF activation leads to low-grade inflammation and injury. And so we know that in all these diseases, and Petter has shown this, is that there's basically a drop in ATP production, a drop in oxygen consumption, and a shift from mitochondrial function to more of a glycolytic pathway. And this is protective acutely, but chronically is not. Now, interestingly, we've been studying the hibernation pathways, and what happens when an animal hibernates is it activates, it actually eats a lot of fructose generally, or makes fructose, and then that stimulates food intake. And there's also a shift where they try to basically reduce their mitochondrial function too, and reduce their metabolism as a mechanism to store fat. But when they switch to burning ketones and so forth, what happens is that the number one criteria for that is a reduction in food availability. And when that nutrient availability falls, then the animal shifts into a program where they reduce their metabolism, live on ketones, and so forth. So I do think that the SGLT2 inhibitors, by blocking glucose uptake, they're blocking the nutrient being provided, and they're also blocking the conversion of the glucose to fructose because they're blocking the glucose. So that whole process stops this kind of Warburg effect and shifts it more to a ketone burning effect. So I actually sort of agree that this does fit an estivation pattern, but it's actually linked with this, with these general system that you're kind of reducing HIF-1. You're basically changing how the tissue lives in the setting of poor, in the setting of where nutrient availability is low, oxygen is low, inflammation's high. So it's shifting it towards more of an estivation type of phase. It's true that would be protective. And when we wrote about the Warburg effect, we were kind of looking at the proximal arm, but I think that Jens is looking at the distal arm. They actually connect.
Thanks, Rick. Any other questions for Amy? Amy, I had a question regarding maybe a comment and a question. Is you raised like a good issue about ADH elevation in advanced heart failure. That's one of the issues that actually, if you look at most of the studies that have done SGLT2 on progression of renal disease have not included PKD patients. And that one of the concerns is that it may raise ADH and make the disease worse. And actually the animal models are pretty much on both sides of the fence. But I guess my question is on fibrosis. Of the studies that you reviewed, is it more on cardiac fibrosis or renal fibrosis? Were you able to find anything on kidney fibrosis?
It's interesting. So I think one of the studies showed With the stains, they didn't specifically say anything about ADH, which was kind of a shame. And I think what I was reading is a lot of problems with it was actually being able to measure the ADH, which I think most people who study ADH have to check copeptin levels, if correctly,
Yeah.
just because it's super hard to measure ADH. And so a lot of the studies I saw didn't really comment on ADH. The best one I could find on fibrosis was the SGLT2 inhibition in a proteinuric diabetic mouse kidney. And it did seem to show that there was decreased fibrosis, but whether or not it was how it related to ADH, I'm not entirely sure. That there was something very interesting. I didn't talk about this. Dr. Teitelbaum in mind. Very small.
Sorry, Amy, you're coming in and out.
Oh, sorry.
That's okay.
Okay. Is it better now?
Yes, better. Mhm.
Oh, okay. So there was a study that was trying to argue that ADH does help with peritoneal fibrosis in PD patients, which was kind of interesting. It had something to do with ADH. I think it had something to do. I don't exactly remember the details of it, but there was that one tiny study that I have saved. I can send it to you or Dr. Teitelbaum if he's interested. But otherwise, no, not a whole lot that I could find.
Yeah. Thanks, Amy.
Yeah, I'd be interested. I don't know that study.
Okay, sounds good. I'll send it to you.
Thank you.
Sure.
Amy, I had one more comment. Real quick. Awesome job. The whole issue on like diets and SGLT2 inhibitors. I mean, I think all the metabolic phenotype of these drugs, and I've said this before, kind of they create ketogenesis, fatty acid oxidation, weight loss. You didn't talk too much about their lipid profiles, but like LDL goes up, trigs go down. You know, all this kind of phenotype is recapitulated in fasting states and also like low carbohydrate ketogenic diets. And I'm just curious what your thoughts are on, you know, we've traditionally shunned higher protein diets, but you know, they're keto diets or low carbohydrate diets in general. You know, there are versions of them that are lower protein intake and just kind of higher fat intake. And I mean, this is at least circumstantial evidence that we might be approaching diet in CKD. It kind of opens up avenues to study, you know, different diets. I don't know what your thoughts, just independent of SGLT2 inhibitors, just as a therapy.
Totally. Yeah, absolutely. I think after all of this, you know, the next thing I was going to look into was kind of the data behind some of these fad diets, like a keto diet, like intermittent fasting, because I was like, oh my God. I think diet might be a huge component of all of this. And I think it actually is, because when I was reading through all of this, and I was like, oh, a high salt diet is bad for a lot of reasons. And you know, the thing that I learned was, you know, potentially a high salt diet, you know, if it really truly does induce this estivation state, and we have, you know, in America, we have all this access to food and all these access to calories, excess calories, you know, that high salt diet drives us to eat even more and more to maintain protein intake, so that our body does what it does. And it felt like a very vicious cycle when I thought about it. And it kind of brought to light how problematic I think the Western diet is. And so I agree that I think diet is super important. Now, whether or not it should be, you know, like relatively high protein or what, like I don't really know. But I think caloric restriction, or at least portion control, is really important. This and the source of protein, I don't know. I don't have an opinion on that, like whether it should be like plant-based protein or animal proteins. I don't have too much of an opinion on that just yet. But I do think that diet is just so important. And I don't know how else to put it eloquently. That is just, I think I've been poo-pooing diet, and now I've been on this like crazy, personally, I've been on this like crazy diet now. Because I think you're right. I think it's really important. And I think it also goes back to one of my, the second to the last question I had was, all right, if you do the dieting thing well enough and you're on a diuretic for volume control, do you see the same benefit as an SGLT2 inhibitor? It's a good question. I don't know. I don't have a great answer, but anyway, I'm just talking out loud now.
Great job, Amy. That was really
Amy.
nice.
Really
Yeah,
great.
that was great. And it'd be wonderful if we could get all of our patients to go on diets, but
No, it's
follow
so
a good
hard.
diet. It's almost impossible. We try. Well, great job.
Thank you.
Great job, Amy.
Great job, Amy.
Thank
Thank you
you.
so much.
Great talk, Amy.
That was
Thanks.
awesome. Thanks, Amy. You're the bomb.
Thank you.
Good job, Amy.
Thank you so much, Ruth. I appreciate you. I owe you.
Oh yeah, girl, I got you.
You're the bomb. Thank you.